Hi, good afternoon, everyone. I'll be talking about pacemakers. These are we do all these things, pacemakers, and this is something new in pacemaker conduction system pacing, which I'll talk briefly about today. His bundle pacing, left bundle pacing. We implant defibrillators, we implant CRTs for past couple of decades. The latest is Bluetooth sync technology in pacemakers and devices. This is something new, antibacterial envelopes, which we are implanting nowadays when we implant device, and LA appendage closures for patients with atrial fibrillation, thromboembolism. Now, conventional pacemakers are, which we've been putting for last 3-4 decades now, are single and dual chamber pacemakers. And conventionally, the leads used to be put in the RV apex. This is a picture showing that this is what the pacemaker is, which is put just below the collarbone, below the clavicle. It is either subcutaneous or submuscular, and the lead goes either into the RV apex or in the RV appendage. So it's ventricular based or atrial based or dual chamber pacemaker. If you have, this is what used to be done like 20-30 years ago for most of the patients. There used to be one lead which goes into the RV apex, and that used to give rise to a wide QRS. You know what a normal ECG looks like. It is sinus rhythm, P followed by QRS. The QRS is narrow, but here the QRS is wide. It's in the RV apex, so it gives a LBPP pattern, and it's a left superior axis. Now, what happens with that is you're stimulating this part of the ventricle. Normally, the activation of the ventricles is from the sinus node, AV node, and it will simultaneously activate the RV and LV. But here you're stimulating the RV apex. So that changes the pattern of activation of ventricle. That causes ventricular dyssynchrony, and it worsens the LV function. Patients get heart failure. There is higher chances of atrial fibrillation because you lose control over the atrium. So what are the advance over that? We used to put dual chamber pacemaker. So one lead goes in the atrium and the other one is in the ventricle. So you've restored the AV synchrony. So now you have P followed by QRS. So AV are now synchronized, but the ventricular problem is still there. There is ventricular dyssynchrony. The RV is not consonant with the LV. Higher incidence of heart failure, especially in patients who have structural heart disease. So how do we get around that? Then we used to implant patients with heart failure. We implant CRT. One lead in the RA, one in the RV, and the third one goes through the coronary sinus into the one of the veins, and we stimulate the LV lateral wall. And you're simultaneously stimulating the RV and LV, and you now get a narrow QRS. So now you've achieved a better synchrony between the RV and LV. So you have a pacing system with stimulation in the atrium, in the RV apex, in the LV. The AV is now synchronized. The RV and LV are now synchronized. But there are some problems still which remain. Some patients may have MI and there may be a scar there, and you may not be able to stimulate any part of the lateral LV. Or the phrenic nerve, which goes right from there. If you stimulate there, the phrenic nerve also gets stimulated, and the patients may get hiccups and all those problems. Or there may be no veins in that lateral LV region. God has given no vein there. So to get around that, we put quadripolar LV lead. There are the LV lead has 4 electrodes, and we can choose which electrode we can stimulate it from. But often, if the vein is small, then that becomes a limitation. So the further advance is putting a active fixation or screw-in lead into the LV. So I can choose where to implant that LV lead. So gradually we are encountering problems and treating them. So with CRT, we are giving simultaneous stimulation of the RV and LV and synchronized it with quadripolar lead. We are trying to stimulate where we can get the best possible activation. There is a problem with the RV apical stimulation, which still remains, and that is the ventricle gets activated in the abnormal direction. So it is not consonant with the natural wavefront activation of the ventricle. That again worsens the LV function. So how do we get around it? What we used to do over the past decade is we put the RV lead in the mid septum. So we used to screw the lead into the septum. So one lead is in the RA. This is what the RV looks like. This is the IV septum. And instead of putting this RV lead inside the RV apex, I used to screw it in the mid-septum region of the IVS. So that was a little better. But can we do something better? In order to recruit the cardiac conduction system now over the past couple of years world over, in many centers, we are directly stimulating the His bundle. So the place from where the activation of the ventricle starts, we are directly targeting that. Or we can even target the left bundle branch with certain special leads. So this is an example of His bundle patient. Usually you would see the lead either in the apex or in the mid septum, but here we are going exactly at the AV node or His bundle region. Now this is an example of an ECG. It's a complete heart block. The patient has narrow QRS. Now if I put a routine pacemaker, the patient will end up with a wide QRS, ventricular dysfunction, worse problem. So what we do now is during the implant, we look for this His signal. This is A, His, V. Look at the His signal and target the lead. This is special lead to be screwed in that exact point. And in the end, you have a very narrow QRS, which is excellent physiologically for the patient. And that really improves the patient's condition. So this is one of our patients. One lead in the RA, and this is a thinner lead. It's a special lead with a screw which goes into the His bundle region. Same way, we can also target, this is the AV node, His bundle, right bundle branch, left bundle branch. We can actually target the left bundle branch, but it requires a special lead where we screw through the septum into the left bundle. I had shared a few pictures of these on the SIMS group a few months ago. So this is the special lead which goes through the thickness of the IV septum. And this is an MRI where you're seeing the lead going right through and we stimulate the left bundle. And again, you land up with a narrow QRS instead of the wide QRS you would land up with. We can actually utilize it in our CRTs also, putting the lead in this either His bundle or left bundle. We call it hot CRT or lot CRT. And that improves the overall look of the ECG. What would be otherwise wide QRS, now we have narrow QRS, and physiologically it is much better for the patient. Patient's heart failure improves and they do very well. This is all with the pacemaker and routine leads. Nowadays we have these leadless pacemakers also. It is just the size a little bigger than a capsule, and we can just implant it and without leads come out. And just recently, a couple of days ago in the country, we have Micra AV. This is a leadless pacemaker with AV synchrony. And in a few years, probably we'll have a CRT with 3 devices. And we should be able to do CRT with a narrow QRS with these kind of pacemakers. So I'll stop there well within my time, I guess, and invite questions.